Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a consultant talking to a woman whose father has just been admitted to hospital. Now read the question.
So we've talked about the various things that might have caused your father to collapse. A lot of times we investigate multiple symptoms so as to rule out any life-threatening conditions.
So it could take some time to get to the bottom of the problem?
Possibly. In the meantime, he's quite stable now, and we're encouraged by the progress that he's making.
Well, I'm glad to hear that. But at least he's not in any great discomfort, is he?
According to the assessment at the bedside by his nurse, his pain is well controlled, and we'll try to keep his sedation at an adequate level until we're ready to begin treatment.
Question 26. You hear a trainee nurse receiving feedback from her tutor about the ward round she's just completed. Now read the question.
How do you feel your ward round went with that patient?
Oh, I really should have told him what I was about to do, rather than just rolling up his sleeve to take his blood pressure.
Yeah, it would have been preferable, but at least you realise.
Thanks.
I think you did your observations really well, though. You checked the patient's details are correct, you put the date in, you timed it correctly, you observed that all your parameters are within normal range, and you did the respiratory rate while you were doing your manual pulse.
Yes, the pulse was quite strong and regular.
And you could have passed that on to reassure the patient too.
Oh.
But you look back at the previous observations, put your signature at the bottom. That's all good.
Thanks, okay.
Question 27. You hear a hospital nurse briefing a colleague about a patient with chronic obstructive pulmonary disease, or COPD. Now read the question.
So who's next?
The patient in bed 12. She had a fall at home about a month ago, but she's otherwise independent with her day-to-day activities. Her falls risk is high given her recent history. She's been assessed by the physio, and she's on a rollator frame to ambulate. Her skin integrity is intact, and she's responded well to all treatment.
Good.
She's on a normal diet. The observations were last done at 6 a.m., and they were stable. Her medications are IV tazocin due at 2 p.m. and prednisone next due at 8 a.m. tomorrow.
Okay.
You need to check with the doctors today whether she'll continue with the IV antibiotics and whether the cannula can be removed. At this stage, they're aiming for discharge in a couple of days' time, pending discharge from the physio and also ceasing IV antibiotics.
Okay, thanks.
Question 28. You hear 2 hospital managers talking about a training session for people who do voluntary work with patients. Now read the question.
So how do you think the volunteer training course went?
Well, we had a reasonable turnout, considering that these people already give up their free time to drive patients to appointments, visit inpatients, all sorts of stuff like that. It's quite a lot to ask. It's a wonder so many managed to fit in the training too.
And they did seem to get something out of it, if the feedback sheets are anything to go by. From my point of view, though, I just wasn't sure whether it went into issues like customer care, confidentiality, that kind of thing, in enough depth.
Well, that's something we can always look into before we roll out any more.
Well, I think we should.
Question 29. You hear a pharmacist talking to a doctor about a patient's medication. Now read the question.
Sorry to bother you, Dr. Baker. I just wanted a quick word about Mrs. Milton's prescription, the one for anti-inflammatories that you gave her after last week's consultation.
Oh, yes, for her osteoarthritis.
Yes, so she's been on them for a week now, 500 milligrams twice daily. The thing is, she's just been into the pharmacy complaining of a headache ever since she started the medication.
Really? Well, that does happen in some patients, but maybe switching her onto a different anti-inflammatory wouldn't be a bad idea.
OK, I'll look into some options and then run them past you later, shall I?
Fine, thanks.
Question 30. You hear a surgeon talking to a member of his team as they are finishing a surgical procedure. Now read the question.
Good, there's no more bleeding. The procedure's finished.
Can we just do the sign-out? How much contrast did we use?
That was 120 mils of Omnipaque, and we did reach a high dose, so I'll have to fill out a high dose form. I'll do that afterwards. The other thing was that the ultrasound machine was giving us a few problems.
Yeah, I'll have to get the technician on the phone.
Do it now, though, because we'll need it if we're going to get through all our lists today.
Do we need to send this patient up to HDU?
Actually, everything was quite straightforward, so I'd say a regular ward bed is fine.
That is the end of Part B. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with Dr. Bob Dean, who's talking about a trial he conducted to assess different ways of treating the condition known as tennis elbow. You now have 90 seconds to read questions 31 to 36.
The condition commonly called tennis elbow is a painful condition of the tendons which interferes with tasks involving gripping and manipulating objects. A recent trial led by Dr. Bob Dean has tried to see what type of therapy works best. Bob, is there a typical way that tennis elbow starts?
It's a very common condition, but apart from tennis players themselves and people working in industries where they do certain manual tasks, it's surprisingly difficult for patients to pin down the actual start of the pain. And even with those high-risk activities, it's generally something that comes on over a period of time. In tennis, it used to be said it was down to the player's grip or the type of racket they were using, but nobody's really researched that thoroughly. There are plenty of guidelines out there, but they're not evidence-based. When somebody has pain, then modifying their tools, whether that's a tennis racket or something at work, may well help, but that doesn't necessarily mean there's a causal link.
So what was your approach in the trial you conducted?
Well, we divided our patients into 3 groups. One group followed a physiotherapy program, another was asked to do nothing to see if the condition just went away by itself, the wait-and-see group we called them, and people in the third group were given steroid injections. The physiotherapy we used was a specific elbow manipulation. The therapist applies manual force to the elbow joint, and at the same time, the patient actually performs the kind of task that causes the pain. The aim is to apply the force in a way that relieves that particular pain. But just as important is the physical activity the therapy calls for, because in most tennis elbow patients, their muscle system's quite debilitated.
And I understand that complete rest wasn't seen as an option. Instead, you described something called smart rest?
Resting's an interesting thing. Immobilizing the arm in a sling is probably the worst thing anyone with tennis elbow can do. In fact, resting most musculoskeletal pain isn't good. What we advocate is something called smart rest, and what this means is being as lively, as dynamic as possible, but not hurting the elbow. An example is where patients avoid picking things up with their palm facing down, which is classic advice given to anyone with a condition. But patients do need the stimulus of movement to help rehabilitation. And so all our participants were given advice on how to manage their condition ergonomically, even the wait-and-see group. The difference was they didn't get any other form of treatment, whereas our other 2 groups did.
So what were the results?
What we found was that steroid injections were more effective in the first 6 weeks, but not after that. The physiotherapy group also reported good results at 6 weeks, comparable to those for the injection group, and much better than those reported by the wait-and-see group. But then, after 3 months, the situation had changed. The physiotherapy group was now reporting better results than the injection group, and, remarkably, so was the wait-and-see group. Indeed, they were catching up all round, so much so that after 6 months, physiotherapy is no more effective than doing nothing. At 12 months, and what's fascinating is that we're the second study to show this, the recovery rate for people who do nothing was 70 to 80%.
So what does all this mean for patients? What advice would you give them on the strength of this trial?
I'd say, in the first instance, rest the elbow and see how it is in 3 months. If it hasn't resolved itself by then, they're probably one of those 20 to 30% who aren't going to get better. At that stage, I'd recommend they have some sensible physiotherapy. I don't think there's much evidence to support the use of steroid injections until a really good attempt's been made with the wait-and-see approach backed up by physiotherapy. But it's still worth trying at that stage because the alternative could be some quite drastic measures, even possibly surgery.
I see. Now, it's quite common for people to think that if something's sore and swollen, they've got to take anti-inflammatories like ibuprofen. Are they right?
Well, there have been various studies about this, and what they've found is that there's little evidence of inflammation in tennis elbow. So there's no reason to think that non-steroidal anti-inflammatory drugs are going to be very beneficial. So I suspect that just taking basic over-the-counter pain relief would be at least as successful as taking anti-inflammatory drugs, in the case of tennis elbow.
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a presentation in which a researcher called Dr. Sarah Jones is talking on the subject of weight loss interventions by GPs. You now have 90 seconds to read questions 37 to 42.
My name's Dr. Sarah Jones. Today I'm going to be talking about brief interventions for weight loss. What that basically means is helping patients to get started on the road to losing weight, and I'll be introducing you to some exciting new work on the subject. I've been interested in obesity for a long time, and it's an issue that matters. 2/3 of adults in this country are overweight or obese. So I absolutely recognise that we need interventions which can be part of routine care. The reality is, however, that relatively few practitioners actually make such interventions, despite the fact that this is an established part of clinical guidelines in many parts of the world. Now, why is that? One reason, I think, is that they tend to have an attitude that goes, "What can I really achieve in a brief intervention?" Now, that's a reasonable concern. But when we did a review of weight management services led by health professionals, there were so few of them that it was difficult to know whether or not they made much difference. As a result, we decided to do our own trial, which we called Brief Interventions for Weight Loss. What we did was train GPs to make a very brief 30-second intervention with every patient coming into their routine clinics who had a BMI greater than 30. Basically a brief chat saying, "While you're here, have you thought about the benefits of losing some weight?" The reason for doing this was to get patients who weren't really thinking about their weight to focus on it for a moment. If the doctor raises the issue in this way, we can capitalise on that heightened awareness by offering them support. By referring them to a program, we can create lasting motivation to lose weight. So, that was the theory. How did it work out? What I'm going to say next should provide huge reassurance to practitioners. Our first step was to conduct a survey of 500 likely candidates for the trial. Although weight remains a very delicate personal issue in the public domain, only a tiny proportion of those surveyed thought it was inappropriate for their doctor to discuss weight loss on a professional basis. Given the need for urgent action on the issue, I think that's a pretty strong mandate. Anyway, as I said, this was a trial, so there were two groups of patients. With patients in the first group, the doctor formally raised the issue of weight and offered a referral to a weight management program. For patients in the other group, which was the control group, the doctor simply said, "It would be good for your health if you lost some weight." So what happened when this weight loss intervention was trialled? Well, the answer is that 3/4 of those offered referrals said, "Yes, doctor, I'd like to do that." That was an excellent start, but we're realists. And of course, they didn't actually all turn up. But nonetheless, a large number did. Of those who accepted the referral, more than half attended the program. Now, that's a fantastic result, exceeding our expectations, and indeed most of them completed it. So given that it was a completely unselected, totally opportunistic intervention, we were quite encouraged at the uptake for this program. But of course the crunch is, what happened to their weight? Well, at 3 months, people in both groups had lost weight. The control group, you remember they'd simply been advised to lose weight, but were left to their own devices in terms of what they did about it. Now, they'd lost 1.75 kilos on average. Meanwhile, the group attending a weight management program had lost significantly more, about 3 kilos. When we followed both groups up again at 12 months, patients in both remained below their baseline weight. But the intervention group had again done significantly better than those people left to manage their weight independently. This is an interesting trial because it allows us to model what the effect would be if GPs made this kind of brief intervention more widely, just once a year for each eligible patient. So, how scalable are the results? By 2035, run countrywide, such an approach could reduce the prevalence of obesity by half. That's a dramatic result, showing that these brief interventions not only help individuals, but could also lead to huge gains for everyone in terms of better health and reduced healthcare costs alone. So, to sum up, I guess what I want to convey to you is that brief, opportunistic interventions from a doctor to encourage weight loss, when made in a supportive manner, are really to be encouraged. Thank you.
That is the end of Part C. You now have 2 minutes to check your answers. That is the end of the listening test.